we're going to move to our next session of the day, which is heartburn and reflux. And that will be another patient and physician combo.
So the first talk is going to be by Dr. John Pandolfino, who you all know. He's one of the moderators of this program and is the division chief of gastroenterology at Northwestern University. And he's going to speak on the physician introduction on heartburn and reflux. And then we're going to have the patient perspective on gastroesophageal reflux disease. And that's going to be given by Luiz T, Jr. And then the third video is a physician introduction on eosinophilic esophagitis, and it's going to be given by Dr. Dellon at the University of North Carolina in Chapel Hill, and he is really a world expert on eosinophilic esophagitis. So we're in for a real treat. And then the last video is the patient perspective on eosinophilic esophagitis, and that's going to be presented by Eric Taylor. So I hope you enjoy all of the sessions.
My name is John Pandolfino, and I'm a professor of medicine at the Feinberg School of Medicine, Northwestern University, and chief of the Division of Gastroenterology and Hepatology, Northwestern Memorial Hospital. And it's really my pleasure today to talk to you about a physician introduction to heartburn and reflux, and really what you can glean from how we approach patients who present with substernal burning in the chest, which is heartburn, and of course reflux and the various symptoms and complications that can occur with reflux. Now, the definition of GERD is considered to be a condition where you develop troublesome symptoms or complications related to reflux of gastric juice from the stomach into the esophagus and the throat. And this can actually lead to a whole heterogeneous symptom and complication profile, as you can see from this particular slide. You can present with the classic symptoms like heartburn, regurgitation, chest pain, but you can also have these other complaints like cough, laryngitis, pulmonary fibrosis, a sore throat. And then, of course, there are the extreme complications, inflammation and esophagitis, stricture, Barrett's esophagus, which is a premalignant condition, and cancer. And when you look at this slide, what I really want you to take away from this is that it would be illogical to think that we would work people up and treat people the same, regardless of what the symptoms are. We would not treat everybody. It's not one size fits all, because there are different types of disease presentations. So I'm not going to treat the patient with cough the same way I might treat the patient with heartburn. So it's just something to keep in the back of your mind. Well, what is the mechanism that drives GERD? Well, we know that we are focused on gastric acid and the gastric juice, and certainly that is an important component of this. But it is important to realize that the gastroesophageal reflux disease pathogenesis is not related to people having too much acid or making too much acid. In fact, if you look at normal people and GERD patients, they make about the same acid. There are some hypersecretory diseases, but for the most part, they have similar gastric acid profiles. Really, what differentiates GERD patients from people who don't have GERD is how much of that gastric juice moves up into the esophagus and the throat. And really, the things that promote that are obesity, delayed gastric emptying, increased volume, and these physiologic events that happen at the lower esophageal sphincter, which is really part of the protective barrier preventing reflux. And then, of course, once you do reflux, there are other things that help you or protect you, like saliva production and motility in the esophagus, moving the bolus and the liquid down back into the stomach. And then, of course, hiatus hernia is another important part, because this really causes a disruption of that anti-reflux protective barrier. Now, as I mentioned, though, even though GERD is not a disease of abnormal amounts of acid in the stomach, the target of our PPI, or proton pump inhibitor therapy, is really focused as a compensatory treatment and not curative. Really, what we do is we just reduce the acidity of the gastric juice so that when you actually have it in your esophagus, it's not as irritating or noxious. The problem with that is that a lot of people do fail proton pump inhibitors. And the reason why they fail the proton pump inhibitors is that maybe their symptoms are not related so much to the acid as it is to the reflux of the gastric juice. Because even if you reduce the acidity of the gastric juice, the refluxate is still pretty nasty, and it certainly can still injure the throat and the lungs. The other reason why people may fail PPIs is that they actually don't have reflux. And it's really important for us to think about this because many people come in with heartburn or chest pain, and they actually have a completely different disease state. So in the back of our mind, when people are not getting better on good, effective PPI therapy, we have to think that maybe we're barking up the wrong tree. Now, GERD can injure the esophagus, as we saw on that slide on the definition. You can see it can have various degrees. So there can be some mild injury, moderate injury, and severe, where you see these deep ulcerations all around the end of the esophagus. And then, as we mentioned, Barrett's esophagus, where although it is a pre-malignant lesion, the risk of cancer is low, but you really need to make sure that you follow with your doctor. Because if we diagnose Barrett's esophagus, you're not going to die of esophageal cancer because we're going to keep an eye on you and we're going to do surveillance endoscopy. If we ever see anything that's bad, we're going to take care of it. So really important to remember that even if you get that diagnosis, don't be disheartened because we can really survey you and protect you from getting esophageal cancer. So what are the key messages around this? Well, I think some of the key messages here is that GERD can be associated with a lot of symptoms, but heartburn and regurgitation are usually the most common. But we have to remember that reflux can be made worse by a lot of things like trigger foods, weight gain, bad anatomy, and physiology. But with that being said, we can actually treat these particular problems by focusing on some of these lifestyle modifications that will reduce the triggers by reducing trigger foods, reduce the gradient in terms of weight gain, and address some of the issues with bad anatomy and physiology with maybe how we're positioned when we're sleeping and how we're eating. And that's really where we focus. The treatment is focused on the problems that are driving reflux. So we'll modify diet and encourage weight loss. We'll look at medical therapy to suppress or buffer acid. Antacids and H2 blockers, which are famotidine and ranitidine, are very effective on-demand therapies. So usually for people with mild disease, pretty erratic symptoms, maybe less than once or twice a week, those patients can get away with on-demand therapy. But if you're having symptoms every day or more than 3 times a week, it's probably reasonable to take something like a proton pump inhibitor, which is a medicine that actually can suppress acid for the entire day. And you take it once a day and it's very effective. Now, there are certainly some more aggressive approaches that would require surgery and endoscopy that could effectively treat the anti-reflux barrier and prevent you from getting reflux, where you can maybe stop your proton pump inhibitors. But as I mentioned, sometimes reflux symptoms may be caused by something other than GERD, and you should definitely see your healthcare provider if these medications or medical therapies are not working. Now, as I mentioned, antacids buffer acid in the stomach. They're predominantly on demand, just like H2 blockers. They can suppress acid and work quickly, but they're not as strong as proton pump inhibitors. So I like to use antacids for my patients who have, maybe a little bit of reflux after a dietary indiscretion. H2 blockers, which suppress acid, they don't just buffer acid like antacids, a little bit stronger than antacids. I use for people who probably have a little bit more severe symptoms. They know when they eat late, they're going to have symptoms. That's another on-demand medicine that I'll use. But if someone has pretty significant disease, that's where I use proton pump inhibitors, which are omeprazole, lansoprazole, pantoprazole, rabeprazole, dexlansoprazole, and esomeprazole. So what are proton pump inhibitors? Well, they're exactly what they say they are. They block the proton pump in the parietal cell. The parietal cell is the cell in the stomach that makes acid. And when it is activated, the proton pump can actually block that. Now, this is a little bit of a simplification of the slide because you really need to have that actual proton pump in your system about 30 to 60 minutes before it can actually block the acid pump. And it actually has to come in through the parietal cell. So once again, a very important component of this is the timing with meals. And how do they compare with H2 blockers? Well, certainly if you look at this graph, the purple color representing the H2 blockers and the yellow and the gray color representing PPIs or proton pump inhibitors, you can see that the relapse of esophagitis, meaning the inflammation, is much lower in the patients who are on the proton pump inhibitors, whether they're using a healing dose or a maintenance dose. Now, in terms of our algorithm on how we approach this, well, if we see people who are failing compliant PPI therapy, these are the patients that we do refer for further evaluation. That being said, though, we got to realize that there is a difference in the potency of some of the PPIs. So some PPIs are stronger than the others. And this is the actual hierarchy. So pantoprazole at 20 or 40 milligrams is the weakest PPI. So if you're on that particular dose and not responding, you may benefit by going to a higher potency PPI like rabeprazole or esomeprazole. So that is really the point of this particular slide. Now, as I mentioned before, PPIs work best when they're timed with your meal. They need to work or block activated pumps. So patients are instructed to take their PPIs 30 to 60 minutes before meals so it can be absorbed in the small intestine, get delivered through the blood to the parietal cell, and then within the parietal cell, it gets secreted into what we call the canaliculi, where they can actually block the acid pumps. So really important to remember that this particular timing gives you the best bang for your buck when you're trying to suppress acid with reflux disease. Now, there is one combination of omeprazole called Zegerid that can be taken on an empty stomach at night that can work very similarly to the timing with a meal, because it tricks the stomach into thinking there's a meal because it has a little sodium bicarbonate. Now, it's really important too to make sure that patients follow up, or you follow up with your healthcare provider in 4 weeks, because most people will notice an improvement in their symptoms. And if they're not really improving in 4 weeks, you can use that opportunity to kind of stratify or augment them in terms of their PPI dose and try to improve their compliance and adherence to that dose. But once again, we always want you to consult with your healthcare provider if you were thinking of stopping your medications, because stopping your medications can cause complication, especially if you have chronic reflux with severe injury like erosive esophagitis, the kind of Los Angeles C&D that we saw on those slides, Barrett's esophagus, and certainly strictures. So as I mentioned, the PPIs are very effective, but they do require this delicate interplay between the timing of the meals. But, you know, all of reflux is not related to acid. And remember that even though you might improve the acid level or reduce the acid level in the gastric refluxate, this gastric refluxate still has bile and it still has digestive enzymes, and that can still injure the esophagus. Now, PPIs, although they're effective medicines, do have some things we need to consider: side effects and reactions, theoretical consequences of acid inhibition, and some drug-drug interactions, and this is some of them. The most common side effects and reactions with PPIs are headache and diarrhea, but you can pretty much see anything. If someone has a distinct symptom after they start a PPI and it goes away when they stop their PPI, then it's probably a side effect of the medicine. There are some theoretical consequences of acid inhibition that are related to potentially changing the pH in the GI tract that may lead to specific problems. And we'll talk a little bit more about this as we walk through the PPI safety issues. And then, of course, there's some drug-drug interactions where your doctor will probably make sure that you either change your medicine or alter your dosage of Dellon, warfarin, diazepam, and clopidogrel. So once again, I think your doctor is going to be keyed in on that. Now, that being said, as I mentioned, there is a lot of anxiety regarding PPI use in the lay press, and we believe that the risk-benefit ratio is in favor of PPI therapy in patients with GERD complications, and those who have GERD documented who are unable to stop PPI therapy to continued GERD symptoms or the risk of GI bleeding. Now, PPI therapy has been associated with a risk of C. difficile or Clostridium difficile colitis, and patients should be advised. So if you do develop diarrhea, you certainly should think about this and talk to your doctor about that. PPI therapy does not need to be altered, though, in certain other indications, like people with osteoporosis or even people on some medications like clopidogrel. Once again, talking with your doctor. But in the end, long-term PPI use is considered safe, and the risks of these adverse events that are theoretical in nature and really only found in retrospective, poorly done studies, such as dementia, chronic kidney disease, bone disease, cardiovascular disease, gastrointestinal cancer, and nutrition or nutrient deficiencies, have really not been proven. And once again, we think that the risk-benefit ratio in the right patients is really highly in favor of continuing PPI. Now, in the end, when we discuss PPI safety, we still have to realize that lifestyle modifications to reduce PPI requirement is still very important, especially in patients with uncomplicated GERD, because our ultimate goal is to get you on the lowest effective dose of medication. And these recommendations would include weight loss for patients who are overweight, head of the bed elevation and avoidance of meals 2 to 3 hours prior to bedtime in people with nocturnal symptoms, and then of course smoking cessation, because this is something that we should be doing for everybody. But that being said, smoking can make reflux worse, and we should look for that. And then of course avoidance of excess intake of caffeine, fatty foods, large meals, and acidic foods that trigger your reflux. I will tell you that I do not expect all of my patients to avoid all of these particular foods, because I don't want to destroy their quality of life by making them too focused on all the foods that can cause reflux, and they really only target the actual foods that trigger their symptoms. So in the end, this is a very global approach to reflux, focused primarily on our medical approach, and then the potential utilization and issues with utilization of PPIs, and how you can make yourself and self-manage reflux throughout your life. So thank you very much for your attention, and I hope you have a healthy meal without reflux by using these particular hints and facts that I've provided. Thank you.
Hi, my name is Luiz Yamashita. I'm 39 years old, and I'm here to talk about my experience with acid reflux. A little background: I was born and raised in Brazil, São Paulo, Brazil. My mom, she's living, and most of her adult life, she has had acid reflux. So I think I get a little bit of that from her side. And growing up, I always saw her having terrible pain, and as part of what she had to do to fix that, she had to go through a surgery, because the valve that keeps her acid in her stomach was not functioning properly. So she had to go through surgery to fix that. And once she did that, that problem was pretty much gone. But this was almost 20 years of her having pain and having to deal with acid reflux on a daily basis. I pretty much started to experience this as well in my early 20s. I would say more severely. In my teenage years, I did have a little bit here and there. I grew up pretty much eating vegetarian, not because of any options other than I used to get really sick. So I don't know if that has to do with any of that. But my parents are, eat meat. They eat meat every day. They love to do the Brazilian, steak. We call it churrasco, and that's very popular in our country. And but for me, for some reason, I never really had a good experience with any kind of animal protein related, food. So I would say that maybe, I wonder, that has something to do. Maybe my stomach is somewhat sensitive, but I never got down to really link that to the acid reflux situation. So again, in my teenage years, I used to maybe have a little bit of heartburn. As I got close to my early 20s, it got a little worse. Not bad, but I remember one day just kind of I get very nauseous sometimes if I eat something that doesn't really go well, and it could be related to the dairy, history, or the animal protein history that I have explained. And one day I noticed that I was vomiting and it had a little bit of blood in it. And I went to the doctor, and they did an endoscopy. This was when I was about 21, I think. And they found out that I had small little ulcers in my stomach. They were gastritis. That's how they had explained to me. So I just took a little bit of omeprazole, control my diet, and over the years, it got fine. But as I got into my 30s, then my acid reflux got a little bit worse again. So as a young adult, you don't think this is anything that you need to worry about, and I just kind of let it be. Try to control it with diet, maybe avoid certain foods. Unfortunately, I like very, very spicy food, and that can be I guess another problem, but even though some doctors said sometimes it's not really the cause of it. But in any case, I started to have this acid reflux and heartburn pretty bad. I would say almost 3 to 4 times a week, which was bothersome and something that you just don't want to be living with, right? So I would say for about 5 years, I dealt with this situation as best as I could. And I finally decided to go see a doctor. And when I went to see a doctor, they did an endoscopy, and they found that I had a polyp on the base of my esophagus where the junction is with my stomach. And that polyp was pretty big. And it was almost to the point that was blocking about 75% of that kind of a hole where the food goes through into your stomach. And that was pretty much caused by the acid. In addition to that, because the acid was going up, sometimes coming up to your throat, to my throat, the doctor also noticed that the results of the endoscopy indicated that there was a sort of a count that indicated I was pretty close to having ENO, which is an inflammation of my esophagus. And at that time, he prescribed to me omeprazole 40, I think it's 40 micrograms on a daily basis for 6 months, and see how that would do, and come back in 6 months to do another endoscopy. So I did do the omeprazole. It was for about 6 months, went back, did another endoscopy. That was, a good thing because it showed that my stomach polyp plus the esophagus had calmed down quite a bit, but the polyp was still there. So they actually sent me to, we are in Charleston, South Carolina. So we have a very good hospital called MUSC, and the expert, Dr. Hoffman there, she, did another endoscopy as well, just to check on it and confirm that I didn't have to remove anything, that would be somewhat worrisome. So with this other endoscopy with Dr. Hoffman, she, confirmed that the polyp had gone down, and pretty much, as long as I stayed on medicine, and I could go down to omeprazole 20 at this time, I would be fine going forward. And she said, as long as you stay on your medicine, watch what you're eating, that will help you stay pretty much, in a good condition and not experience heartburn. So this has been probably 2 years to 3 years now, I want to say. And since I have stayed on the medicine, it has helped me, not experience that. And if I forget to take the medicine, or if I take the medicine for whatever reason, I had to eat right after that, in less than 30 minutes after I take my medicine, then I could sometimes experience a little bit of a heartburn. And I had a day actually that I don't know what it was. I probably forgot to take it, and it was pretty bad again. So it doesn't happen again. Maybe it will happen twice a year now, and it's just something that it's a lot more manageable than before, when I had to deal with this from, eating anything and experience that almost on a daily basis. And I feel that, staying on this medicine has really changed my lifestyle. I can enjoy going out to eat. I don't have to worry too much about what I'm going to eat. I can eat some of the things that perhaps maybe before I was a little bit more worrisome, because I knew it was going to give me heartburn. Anything fried usually did that to me. And in addition to that, I try to be more mindful about what I was eating. So in general, I try to eat healthier, not as heavy. I'm, again, vegetarian, so I try to eat more of steamed vegetables instead of fried vegetables. So I try to focus more on healthy options if I can find them. Of course, if you travel, sometimes it's a little harder to find what you're looking for. But because of this condition, you kind of learn, what kind of options you have. You go, for example, like we go to Outback Steakhouse, and it's a steakhouse, but they have great veggies there. So I try to stay with that kind of option. If it is something that I can ask, get a baked potato, kind of stay within a menu that makes me feel comfortable. And in addition to that, I became more conscious about eating in general. And I think that improving my eating habits also led me to become more mindful about exercising. So I have exercised more often. And I think as a package, the eating and the exercising plus the medicine has helped me to control this and not have this as a worry that I used to have, in the past from feeling sick and having a lot of side effects. So in general, I would say that, if anybody is experiencing any sort of heartburn, sometimes, yes, it does, it can happen to anybody, but if it is becoming more recurring in your life, I would advise, anybody to see a doctor, go get an endoscopy, look, and see what's going on and try to address this, because I hear that your stomach and your, whole gastro, system is very sensitive. And if you get cancer or something like that, it can be really harmful. And that can be an issue for, for something that you cannot really fix. So I'm glad that I got to do this. I'm glad that I can share this story. I'm very excited that this is going out to a lot of people that perhaps will be experiencing similar, problems that I had. And hopefully this will give them the, the nudge in the right direction to have a better lifestyle. Because at the end of the day, I think what you want to do is just have a good, living experience, and not experience this kind of, side effects that can be very harmful to your body, and to the point that, sometimes it can be a pretty severe situation.
Hi, my name is Evan Dellon. I'm one of the adult gastroenterologists at University of North Carolina School of Medicine in North Carolina. Today, it's a pleasure to speak with you and provide a physician introduction on eosinophilic esophagitis. These are my disclosures. And for the talk today, this is the overview. I'd like to help define what is eosinophilic esophagitis, and specifically talk about symptoms, the endoscopic findings, and the histology that lets us put it all together to make a diagnosis, then discuss some common EoE treatments, and review the long-term approach to EoE. So before we talk about the condition, I'd like to talk about what is an eosinophil. So an eosinophil is a white blood cell, and this is a smear of all the white blood cells in the blood, and there's the eosinophil in the top right. And it's one of the kinds of white blood cells that is normally detected in low levels in the blood, and it has a main role of fighting infections. Now, importantly, we never see the eosinophils normally in the esophagus, though you can see them in other parts of the GI system. When we think about the functions of the eosinophils, here they are, the schematic. They have a central function where they not only respond to different stimulations like infections and tissue injury, but also have a role in allergy. And they can talk to other immune cells, like things called T cells and mast cells, and they can secrete or release a number of factors that cause inflammation. And that's where they can lead into both a normal response and into allergic troubles. So what is eosinophilic esophagitis? Well, we have this conceptual definition that EoE represents a chronic immune-mediated esophageal disease characterized clinically by symptoms related to esophageal dysfunction and histologically by eosinophil predominant inflammation. And let me just unpack that. It's chronic, which means we don't have a cure, and it is a long-term condition that's not self-resolving right now. It's immune or antigen mediated, which means it's an allergic process in most people. On the clinical side, you have symptoms that I'm going to talk about. And then when we do an endoscopy and take biopsies to confirm a diagnosis, we can see under histology or examination under the microscope that there's a lot of eosinophils there that shouldn't be there. When we think about the clinical presentation of EoE, we think about symptoms primarily. And in adults and adolescents, dysphagia, which is the medical word for trouble swallowing, is the most common that we see. And in fact, if people have a lot of troubles with this to the point where food actually gets stuck in the esophagus and they have to go to the emergency room, more than half of the time in that situation, EoE is the cause. But it isn't just a sensation of food sticking or choking. It can be a sensation of food going down slowly, or something that's subtle, where people might modify the way they eat by eating slowly, avoiding certain foods, taking small bites or chewing foods to mush, or drinking lots of liquids to help clear the food from the esophagus, or even just worrying about symptoms when they go out to eat. Some people can have heartburn or even chest pain with EoE, and this is sometimes a cause of what would be refractory reflux that isn't getting better with standard antacid treatments. And rarely in adults would you have abdominal pain, nausea, or vomiting. But in children, symptoms are quite different, and they could range from failure to thrive, to feeding intolerance, to heartburn or reflux, abdominal pain, nausea, vomiting, or regurgitation. So much more non-specific symptoms. Now, when you do have those symptoms, it tends that we need to do an endoscopy to evaluate what's going on. And this is the view of a normal esophagus on endoscopy. So we're looking down into the esophagus with a light and a camera. And you can see here it's a very smooth, healthy pink color with lots of little fine blood vessels. And this is the normal appearance. In contrast, in EoE, there's a lot of endoscopic findings. The top left picture here is actually of a food bolus, a piece of food that's stuck in the esophagus, and an emergency endoscopy is needed to clear it out. These are some esophageal rings and signs of scar tissue. This is a very narrow, scarred down esophagus with scar tissue. And then here you can see a much more inflamed and swollen esophagus. You don't see those normal blood vessels, and you see these furrows, which are almost these train tracks that go up and down the esophagus. And then these are exudates or white plaques that can coat the esophagus. And here you also see rings and some furrows and some swelling as well. The lining of the esophagus also tends to be a little delicate in this condition, and sometimes passing just the scope can cause a small tear or fragility of the lining of the esophagus. Then once you have those findings, we have to take biopsies. And this is what it looks like. This is a small biopsy forceps that's advanced through the scope. It takes a small piece of tissue and just leaves a little indentation here where the biopsies were taken in this patient with EoE. And you can see that these are very small, just a millimeter or two in size, and they heal quite quickly. Some people can be sore from biopsies. And then when you look at those biopsies under the microscope, this is what you might see. This is a small piece of the esophagus, and it shows EoE. This is the surface of the esophagus, so inside the tube, and this part of the esophagus is inside the body. And first of all, you can see all of these bright red eosinophil cells that really jump out at you. But you can also see lots of deep purple cells. This is called basal zone hyperplasia, where there's an expansion of additional cells. You can see space around the cells indicating impaired barrier function. And you can see some scar tissue here at the bottom underneath the top layer of the esophagus. Now, if we zoom in on this circle area, here's a close-up of all of these clusters of eosinophils called microabscesses. And you can see that some of the cells here have actually even released all of those granules, those pro-inflammatory granules. And so they're causing a lot of inflammation and trouble in this particular biopsy specimen. So when we think about the diagnosis, we put all of that together. We have the clinical symptoms here that are suggestive of EoE. We do the endoscopy with the findings. We see the biopsies and have to count at least 15 eosinophils to think about the diagnosis. And then we make sure that there's nothing else going on that could be responsible for an EoE for eosinophils in the esophagus, and then we can make the diagnosis. We also think about EoE as an evolving or potentially progressing disease, where it starts with a lot of inflammation with the eosinophils and other cells, and then over time that might lead to scarring. It's otherwise called fibrosis. And the fibrosis is really what gives you the trouble swallowing symptoms in adults, as opposed to the inflammation giving those other symptoms that I mentioned in children. And this may indicate that you have to do more stretching or dilation of the esophagus in adults. Well, why do we treat EoE? Well, we do this to maximize nutrition, help with normal growth and development, minimize symptoms and improve quality of life, help the esophagus look normal and healthy, help the biopsies look normal, and then to prevent complications that are due to this kind of scar tissue like strictures, food getting stuck, or even esophageal perforation where the esophagus can tear. Right now, we do not believe that that EoE is a risk factor for esophageal cancer. We don't think that it progresses to a cancer, which is good news. Now, switching tacks for the last few minutes just to the current EoE treatments. We have both treatments that are non-pharmacologic that don't involve medications. This is diet modifications or stretching the esophagus, and some treatments that involve medications. And there's a long list of different medications that you can use. Unfortunately, we still don't have any medicines that are approved for EoE treatment in the US by the FDA, but there is a topical steroid medication that is approved in Europe and Canada. And I'm going to talk briefly about some of the medications, including the proton pump inhibitors, the topical steroids, and then some of the non-medicine options, including the diet elimination and dilation. So proton pump inhibitors, or PPIs, are medications that you may have heard about. Some names include omeprazole or lansoprazole or pantoprazole, among others. These are typically thought to be heartburn and reflux medications because these meds have a strong anti-acid effect. Well, why do we use them in EoE? Well, it turns out they have good response rates, maybe 40 to 50% of the time. They will decrease the inflammation with the eosinophils and make people feel better. And it's important to realize that if these are prescribed for EoE, it's not really for their anti-acid function. They have an anti-allergy effect that works differently in EoE. They block an allergic factor that seems to bring the eosinophils to the esophagus, and they help improve the esophageal barrier and make it less leaky. So these are often one of the initial medicines that are used. Topical steroids. So what's the concept here? The goal is to coat the esophagus with an anti-inflammatory medication. It's sort of like putting an anti-inflammatory steroid like hydrocortisone onto a bug bite. You rub it and take away the redness and irritation. And since we don't have any approved medications right now, we're adapting asthma medicines and asking patients to swallow rather than inhale them to coat the esophagus. And some medications that are used may be fluticasone, where you puff an inhaler into your mouth and swallow it, or budesonide, where you may mix a liquid into a syrup and swallow it. These are taken every day and are quite effective for decreasing eosinophils in the esophagus, improving symptoms, and improving the endoscopic appearance. And within the next couple of years, if not sooner, hopefully there will be approved esophageal specific medicines, so medicines designed for the esophagus, not for asthma. And in fact, one of these medicines is what's approved in Europe and Canada. Next would be dietary elimination therapy for EoE. Why do we think about this? Well, in most people, EoE is a type of food allergy. And if the food triggers can be found and avoided, this is a very nice treatment. There are generally three overall strategies. There's for very ill patients or for babies, you can use an elemental formula, which has no allergens in it at all. And that can be very helpful, but it's not very practical for longer term use, particularly in older kids, adolescents, and adults. You can use what's called the 6-food elimination diet or another empiric elimination diet. That removes the foods, the top 6 or so that are seen here: dairy, wheat, eggs, soy, nuts, and seafood, and that can also be effective. There's different varieties on this, so not as many foods would be eliminated. And then there's what's called the targeted elimination diet, which isn't used very commonly anymore, where you eliminate foods based on allergy tests. And that's because our current allergy tests aren't very accurate to identify food triggers in EoE. So that's one of the real downsides of this kind of therapy, and it can be difficult to stick with the diet. But the overall goal is to eliminate a number of foods, and then with endoscopies and with the care of your doctor, add one back at a time and assess whether that individual food is a trigger. And then serially add back all of those foods until you know what the set of triggers would be. Last, I'd like to talk about esophageal dilation. Now, this was used if you do have a stricture or narrowing in the esophagus, and the esophagus has to be stretched. You can see here in these pictures a very narrow esophagus. This is a balloon catheter that's placed through the camera. The balloon is blown up, and you can see this dilation effect where the esophagus is stretched. And this is the goal. This is not an adverse effect or a worrisome tear or perforation, but this is the stretch of the esophagus that allows it to be a larger caliber. From my standpoint, it's important to use the dilation in conjunction with other treatments that are getting rid of the eosinophils, because this is just a mechanical treatment, and you need to do something to treat the inflammation as well. Now, there are a lot of new treatments on the horizon, and actually, if you look on the clinicaltrials.gov website, there were more than 35 active or planned clinical trials that are ongoing. These involve things like the custom-made topical steroids for the esophagus, a number of biologic agents that are targeted at factors that we think cause EoE, and some small molecules that also may be targeting factors that we think cause EoE. So it's a very exciting time, and a lot of new treatments are on the horizon. When we think about monitoring EoE, because it is chronic, we have to check you out over time and keep an eye on the condition. And we monitor in 3 different areas. As you might guess, since I've talked about them: the symptoms, the histology and how the biopsies look, and how the endoscopic activity is. And so these are reflected on these scales. And each one of these can be independent of the others. So you might feel better, but the esophagus and biopsies may not look as good. Because of that, we can't monitor symptoms alone. We do rely now on monitoring symptoms and an endoscopy with biopsy at the same time. Over the long term, ongoing care and follow-up are needed. The condition does not go away by itself. Treatments should usually be continued in most patients because we know if they're stopped, the EoE will flare. But treatments can change or be adapted over time. So a single treatment now is not a forever treatment for you. And then we monitor treatments with clinic visits and endoscopies. So in summary, EoE is a chronic allergic condition that causes a wide range of symptoms that are due to both inflammation with eosinophils in the esophagus and scar tissue deposited in the esophagus from the inflammation. There are multiple effective treatment approaches, so talk to your doctor about which one might be right for you at the current time in your life. Long-term treatment is required for nearly everyone, and the condition needs to be monitored long-term, but multiple new treatments are being developed. Now, I'd just like to end by pointing out this patient registry website that I've helped to found with both researchers and patient groups. This is a global patient registry that focuses on patient-centered research. And so please check it out and join if you're interested. Thank you so much for the opportunity to speak today.
My name is Eric Taylor, and I'm here on behalf of St. Francis University and myself. I was contacted to share my experiences as far as my esophageal issues are concerned. So I would like to start off to say I was always one who tried to fight through some things, you know, if I thought things were a little bit menial or minimal, to try to brush it off to the side and not really go get checked out. And I wanted to share my story because I thought that it could be helpful for those who may be having some of the same issues but really don't know what's going on. So I'll make a long story short with how I got here, but then I'll get into some comprehensive information about my surgery and how I'm able to be here today to give this interview. So between 2001 until 2017. So let's just do a span of like 16 to 17 years. One time per year, I would have choking issues. And I thought it was because I didn't listen to mom and dad, where you didn't chew your food up 1,000 times, you know, the traditional mastication of food and swallow it and be okay with everything, because you said, okay, we have to chew our food 1,000 times, and then that is you chew your food correctly and then you swallow. And so that was like the whole common knowledge growing up. But I was having issues in Europe once or twice per year. And then I would choke on maybe, and which I thought was like a large cucumber that was sliced up in a salad, or maybe a large piece of chicken, or maybe a cube of steak that I thought I cut up small enough in order for me to swallow it. So one time per year choking, and this choking would lead to regurgitation of the lodged food. And then that would only happen one or two times a year. And so those 363 other days, I would say, okay, I think I'm okay. Until about 4 years ago, September 2017, where I was on a recruiting trip with my head coach, my former teammate here at St. Francis, Rob Krimmel, and we were at Panera Bread, and I was having a breakfast sandwich before we went out to recruit. And this breakfast sandwich would not go down. So I took a bite, it wouldn't go down. And then I told Rob I had to be excused from the table. Now, me being excused from the table, this is my maybe 20th time to be excused from the table, because one or two times per year, I would have to be excused from the table, whether I'm with a large group, and I would be afraid to say something in front of the group So I would just remove myself from the group, and I would go into the bathroom, and then I would try to dislodge whatever food particles or bolus that I would have in my in my esophagus. And so this one time in July 2017, I was in the bathroom for 30 minutes. And after about 10 minutes, Rob came in. He said, "Eric, you're going to be okay." And I told Rob that I would be okay. And so this was probably the most severe time. This was the most time that I had in the bathroom. And I told Rob that I wouldn't be able to recruit. I was sweating profusely. This piece of food was still stuck in there. Even after 30 minutes, I still felt like it was there. And after about an hour or two after we left Panera, I couldn't go recruiting. I had to go back to the hotel and just relax and become relatively normal as far as body temperature, and thinking that I could be able to swallow again. I mean, not even swallow food, but just drink some water. So that was in July 2017. And I never recruited anymore that weekend. So 2 months later, to fast forward. So we have my issues for 10 to 15 years. Never went to a doctor to get checked out. Had a feeling that I would want to get checked out, but never really made it paramount to go and get checked out by a doctor. I didn't even know I needed to see an esophageal expert, just to go see a general practitioner and say, like, look, I'm having some issues swallowing. Maybe I need some whatever. Maybe I need some chewing classes, or maybe I need some something that's going to alleviate my food tube so that I can swallow better. So anyways, fast forward to September 2017, 6 a.m. in the morning on September the 17th, 2017. I was eating normal breakfast, eggs, sausage, biscuits, some fruit. And I swallowed a couple times, and then it went down okay. Mind you, 2 months ago, I had the issue in Panera Bread. Fast forward, now I'm 2 months later. I'm eating food completely normal. And then I swallow this food, and it went down totally okay. But then I felt a pop in my my upper stomach area. Within seconds, I felt faint. So 6 a.m. eating, 6:05, pain in my upper stomach area. 6:06, I feel like lightheaded. 6:07, I get up. 6:08, the waitress says, "Hey, are you doing okay?" Within 10 minutes, I feel like the left side of my head is going numb. The left side of my arm is going numb. I started to feel my fingers, and they went numb. And then I started to get short of breath. And it's 6:10 a.m. I'm on the ground, and I'm bleeding for my life. So at this time, I actually thought I was dying. So felt like I was having a heart attack. My breaths were getting shorter. I started to think back of like, all right, what was I eating? What was I doing wrong? Like, was I eating something within the last like 2 to 3 years that caused my maybe blood pressure to elevate, or maybe cholesterol elevated, or because I eat relatively healthy up until that point. So anyways, so I tell the waitress, get some nitroglycerin. She didn't have any. I told her to go get some. Within like seconds, someone is on the ground praying with me, and we said the Our Father, preparing me for potential afterlife. And so me being a believer, I prayed. And I didn't know that this was going to be my last second on earth. And fast forward to present day, what happened between the time that I fell on the ground praying, saying the Our Father, to now, I found out that I'm allergic to 10 types of food elements: soy milk, cow's milk, eggs, whites, 3 types of tree nuts, and a list of some fruits. And this was by way of food sensitivity tests with a prick on my skin. And found out, like I said, found out I had those elemental allergies. And also I was diagnosed with the condition of eosinophilic esophagitis. So this is a condition where, in my case, when you eat certain foods that you don't know that you're allergic to, these foods send these allergenic foods, in my case, what I'm allergic to, send eosinophils to the esophagus to fight off these allergens that you intake, creating an inflammatory situation in your esophagus. So your esophagus goes from what's supposed to be like a diameter of a quarter, but over time becomes the diameter of that right there, basically a non-existent diameter, which causes the choking. And so that is, in a nutshell, of the issues that I have, that I had over years, untreated, unchecked. And so to anyone that may be having issues with their gastrointestinal tract, that may resemble things that they may have heard during my testimony, I really recommend that you see a general practitioner or someone of the sort to just really get a check over, get an EDG, get maybe a potential check of maybe your tract, your gastrointestinal tract, just to see like, okay, what is going on? Maybe get an allergy, maybe get a baseline allergy test for if you feel like there could be something going on. Just because I will say that I am a living witness that I was 1 second away from going away from the earth or not living a second more on the real time earth because of taking for granted a potential issue that I had with my body. So listen to your body. If you feel like things are severe enough, go get checked. Right now, I have modified my diet. I am a paleo diet. I have a paleo diet. I stay away from and very minimize my allergic elementals that I know that could potentially cause the eosinophilic triggers. Think about eosinophilic esophagitis, look it up, research it. It's a real thing. I will come out of the taboo and say, like, it is something that a lot of people deal with, especially taller, skinny, tall people, whether you're male, female, no matter what. These are issues that are more prevalent in that population than other populations. And I really hope that someone, if you're listening, that it could help you in your journey as you try to become a little bit more healthy, or try to diagnose some things, or try to get some help in potential issues that you may be having as far as gastrointestinal issues that could be present in your body. So I really appreciate. I wish everyone well, and thank you so much.
Thank you so much for joining us today for the IFFGD Norton Educational Series 30th Anniversary Edition. You just finished watching our very last session of this 2-day program on heartburn and reflux, and we heard from 2 fantastic, well-known physicians and then 2 amazing patients who shared their stories with us today. From this, we do have some questions that we are going to direct to Dr. Che and Dr. Chang. And the first really and truly is in the GERD section. So we get a lot of questions, and we had some questions today about PPIs and the staying on them long term. Is that safe? And then if you have GERD for a very long time, are there risk factors of leaving that untreated or not treated well? So maybe, Lynn, do you want to talk a little bit about PPIs and their safety?
Yeah, so PPIs are proton pump inhibitors, and I don't know, we'll see how Bill describes this because it's described differently. These are highly effective medications for esophagitis, GERD, ulcer disease, but there are a series of large database type trials where they get a lot of information that's stored, and PPIs are very commonly taken, and there have been some associations that have been described that are statistically significant. The question always is, are they really clinically meaningful differences with PPIs and a number of different effects, like on the kidney or on cognition. But the real point, I think, of PPI use is that they're probably overused in the population. Many people may need it, but they stay on it and they don't know if they really need to stay on it. They just continue it. It keeps getting refilled. So the important point is that if a patient really doesn't need it, or they can be on another agent like a histamine 2 blocker like famotidine, then they should really do that, or just try to get off the PPI. Because I just think that if they need it though, and their symptoms are not resolved unless they are on a PPI, then they should stay on it, because the benefit outweighs any risk that's small. But if they can get off it, they should.
And what are those risks?
So a couple comments. First, there are a lot of potential risks. So Lynn touched on chronic kidney disease, bone disease, heart disease. Literally, virtually anything you can think of has been associated with PPIs, but this is the really critical thing for everybody to be aware of. These are associations. They don't prove cause and effect. So for example, if a population of people taking PPIs happens to be older or more obese or have diabetes, they're going to be more likely to have a lot of those other complications, kidney disease, heart disease, bone disease, etc. And it's from those things, not from the PPI. The one thing that has been proven to be associated with PPI use are enteric infections, so gastroenteritis. So for example, if you go to a country where the water isn't clean or the sanitation system isn't up to par, there's a greater likelihood of developing gastroenteritis if you're on a PPI than not. And that makes sense, because if you think about it, one of the main purposes of acid in your stomach is to help sterilize your food. So if you inhibit the production of the acid, the bacteria that you ingest with your food or the water you drink in an unclean environment is going to have a much greater likelihood of getting into the intestine, where it can take root and cause, in some cases, even a serious infection. So that's true. The rest of it is much more smoke than it is fire. What Lynn said is absolutely the bottom line. If you have a clear indication or symptomatically you need to take PPI, then take PPI. Is it safe over the long haul? Yes, it is. But there are many, many patients on PPIs that don't need to be on PPIs, and those patients shouldn't be on PPIs. And so who needs to be on a PPI? Well, if your symptoms only get better on a PPI, there you go. But if you have a known history of erosive esophagitis, so if somebody's done an endoscopy and finds ulceration in your esophagus, you need to stay on the PPI, because if you go off the PPI and you take less potent medications, that esophagitis is likely to come back. If you have Barrett's esophagus, you should stay on a PPI. And if you have eosinophilic esophagitis with difficulty swallowing that gets better on a PPI, you need to stay on a PPI.
Very good. Wonderful. And so what about people who have acid reflux and they have these GERD symptoms, and so they keep the Rolaids or the Tums in their pocket. They're taking a lot of these self-medications, but they're really having a lot of symptoms, but they feel like it's normal for them. They have it controlled. You know, I know that we always at IFFG encourage people to go see a healthcare professional and at least have it checked out. And what are some of the risks that might come if they don't do that, if they just sort of deal with it on their own? What are some things that, is it imperative that they see a healthcare provider? Are there risks to not seeing a doctor?
Yeah, particularly within specific demographics or groups of individuals. So for example, if you're an obese white man and you're having chronic acid reflux symptoms, there's a much higher likelihood of developing long-term consequences, potentially serious consequences, like a precancerous change in the esophagus called Barrett's esophagus, and then in the worst case, actually esophageal cancer. So certainly if you're an obese white man and you're having chronic acid reflux symptoms, you definitely want to make sure you see a doctor. I would even argue that really anybody that's having frequent, and by frequent we typically talk about more than 3 times per week, for years at a time, of heartburn, you should seek the advice of a physician who is going to take a careful history, help you to be on the most effective therapy for you, and also decide on whether additional diagnostic testing like an endoscopy is necessary. So you don't want to leave this to chance, because here's the other interesting tidbit. One of the fastest rising cancers in the United States is actually esophageal cancer. So it used to be one of the rarest cancers in the United States. It's still rare, fortunately. I don't want to scare people too much, but I do want to make this point, which is that of the various cancers that attract, esophageal adenocarcinoma, which is the one associated with acid reflux, is one of the fastest rising cancers in the United States.
I think the more common effects, though, from heartburn and acid reflux is getting inflammation. You can get ulcers, bleeding, and then also when the inflammation is trying to heal, you can get strictures, which is a narrowing in the esophagus, and food can sometimes get stuck.
Fantastic. Thank you so much. And not trying to scare you guys at home. However, it is imperative and is so important that you do talk to your healthcare provider, like Bill said. If you're having symptoms of heartburn or any sort of esophageal symptoms that are more than 3 times a week and are ongoing, please go see a healthcare provider to see if there might be something more going on, or if there's something that can be done to help you and get rid of those symptoms for you. So let's talk a few other questions we received, especially around our patient story. So Luiz mentioned that there was a connection between his GERD symptoms, his reflux, and meat. And that's not one of the things that we hear commonly. It's spicy foods, tomato-based foods, highly acidic foods. Is that common? Do you see that in your practice, meat?
Well, 2 thoughts that come in my mind. I'm hoping it's not dry meat that he's swallowing and it gets stuck, because there's some narrowing or stricture. Mm-hmm. So that's one that you hear often, a piece of chicken or a piece of steak and it gets stuck. And I don't know, if that was really what he was referring to. But also, meat has more fat in it. Mm-hmm. And when people have reflux disease, foods that contain fat are emptied out of the stomach slower. They also cause more relaxation of the muscle, the sphincter that connects the esophagus from the stomach and allows acid to reflux from the stomach into the esophagus. So that might be part of the reason as well. So patients really should try to follow some of the recommendations, dietary recommendations and other lifestyle recommendations to help their GERD symptoms. So maybe they don't need the PPI, the high dose. Maybe they could use, famotidine or something else to treat their symptoms.
Awesome. He also mentioned something about the polyp. So we heard him talk about the polyp that the doctor wasn't concerned about. They waited some time, it did shrink, and things got better. I know that for so many people, you hear the word polyp and it really scares you. So a polyp in the esophagus or stomach area, that's not something to be alarmed if your physician tells you that?
So first, just realize that there are polyps in the colon can be either precancerous or just completely benign. And we get concerned because of those precancerous polyps can lead to the development of colon cancer. In the stomach, it's very unlikely for people to develop precancerous polyps. They're almost always entirely benign. They're specifically called fundic gland polyps. Now, fundic gland polyps are associated with chronic PPI use. So chronic use of proton pump inhibitors creates an environment in which these fundic gland polyps can grow. And they can come and go. So I bet almost assuredly what Luiz was talking about was a fundic gland polyp in the stomach associated with PPI use. And if you follow these things over time, they come and go. And fundic gland polyps are entirely benign. They hold no precancerous predisposition.
So again, that's something to have a really strong conversation with your physician or your healthcare provider to make sure that you understand what types of polyps that you have, and that is definitely a good conversation. So let's move on to, oh, actually there was one other question about dilation, and how is that done? Is that something that you're put to sleep? You have a anesthesia? Is that local, or are you asleep for the procedure, and does it hurt with the dilation?
You know, there's different ways of doing dilation. Most often, it seems now that it's done during the upper endoscopy, during the upper endoscopy procedure. If they see so often they will get a consent just anticipating that maybe there's going to be a stricture, that I'm going to dilate it if I see it. And they do it often like with a balloon, where they open a balloon. And do it very safely, just incrementally increasing it so they can dilate any stricture. And the patient is asleep during that time, during upper endoscopy. There's the other ways that people used to do it, you know, where they would actually be wide awake and pass the dilator into their esophagus and do it even at home. That's not really done that much anymore, but that used to be done, and the patient would know when they would need to do it.
Wow.
But that keeps food from getting stuck, and
Right,
you know,
right.
they'll be so much more comfortable, because you know, as we were talking before, you know, got to be one of the most uncomfortable, you know, experiences is feeling like food is stuck and
really
you can't
frightening.
breathe it. I mean,
Right.
it's scary.
Absolutely. And so let's go ahead and move on to the EoE questions that we received. And some of that is around when you're in that moment and you feel that you have that food stuck in your esophagus. And what can you do at that moment?
So there's probably no more frightening feeling than choking, you know, and so the first thing is just realize that the more anxious and upset you get, the less likely the food is going to pass. Now that's really easy to say. That's much harder to control. But sitting up straight and taking a few deep breaths, maybe even closing your eyes and really trying as best you can to relax, may help your esophagus to relax and allow the food to go through. You can certainly try a small sip of fluid to see if that might lubricate things and help it to go through. But what you don't want to do is start eating a lot more food or drinking a lot more fluid in the hopes that it'll push it through. The reason why I say that is because if it doesn't push it through, then what's going to happen is it's going to accumulate or back up in your esophagus, and when enough food or liquid gets there, it's going to increase the likelihood that it aspirates into your lungs. Okay, so it also makes it much more difficult for the endoscopist, if you need an urgent endoscopy, to dislodge the food, to be able to fish through and weed out all that food that's now stuck in your esophagus. So what you should do is give it a few moments, try to relax, close your eyes, take a deep breath, maybe a sip or two of fluid. If that resolves it, great. If it doesn't resolve it, you know, within some set period of time, then you probably need to come into the emergency room. And there are medications that the emergency room staff can give you to try to relax your esophagus. And if those don't work, you're going to need an endoscopy to dislodge that food that's stuck in the esophagus.
And so definitely something that if you have been diagnosed with EoE, or if you suspect that you might after listening to today's talk, please, you know, talk to your healthcare provider about these things that you can do in the moment, and make sure that you're prepared for that. Even if you haven't had one of the severe episodes yet, make sure that you are well prepared with your physician to know, the severity of your EoE and what is a set amount of time that you should be waiting before you actually do go to the emergency room. Not something that you want to be taking a chance with, for sure.
Cecile, let me just say one thing too, which is that the key takeaway point for the audience is, don't let it get to the point where the food gets stuck like that. Like sometimes the first time this happens, that's what happens. There's nothing you can do about that. But many times, in fact, most of the time, patients will tell you, oh yeah, I've been having some subtle problems for a long time, but it always just goes away on its own. I've just ignored it. And what you want to do is make sure you don't ignore that. Actually, that's dysphagia, or difficulty swallowing, is what we consider a warning sign or alarm feature. And it's an indication to get an endoscopy to understand why you're having that symptom. Okay, so it's better to be proactive rather than at a point where you really get into trouble.
And I think that, Eric really brought that message home, I hope, to all of you in the audience. As he did say, he had issues in the beginning, just like most patients do, and it wasn't until he was laying on the floor in the restaurant and ended up in the emergency room. So please, 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 absolutely, don't let it get to that point. Go see your healthcare provider if you're having any difficulties at all. A lot of times, I think most of us don't take that sort of esophageal disorders as seriously. Everyone has heartburn, right? Everyone has issues, but really and truly, if you have any suspicion at all that you should, do it. It's better to hear that everything is normal and fine than to have issues later.
It's definitely treatable. A lot of esophageal diseases are treatable and, preventable.
Absolutely. So